Thank you so much for your kind invitation and good morning, everyone. Really pleasure with you. I wish we could do that in person, but nowadays I think we take advantage of IT and global communication. So great to be with you, and thanks again for the invitation. And today we will discuss aortic regurgitation. And not only how do we evaluate it by echo and MRI, but also what is the changing landscape? Because there is a changing landscape in diagnosis as well as management of the disease. So it's good to think about it from a comprehensive point of view. To put us in the context of the disease today, this is the aortic valve with its various manifestations in health and disease. On the left, you can see a normal, tricuspid valve, a bicuspid valve, then with some calcifications, a rheumatic disease on the left lower, where the issues are usually in the commissures themselves, much less calcifications. And the other one is, which is very prevalent, at least, in the Western states, and calcific aortic stenosis. And any of them really can lead not only to aortic stenosis, but also to aortic regurgitation. And when we think about aortic regurg, it's not only about the valve, but also the support apparatus and the environment, which is the aortic root and the ascending aorta, but predominantly the aortic root. So from an imager point of view, clinician point of view, these are the situations that you need to address, assess the aortic valve per se, as well as the aortic root to understand the mechanism of aortic regurgitation and non-coaptation of the aortic cusps. The prevalence of aortic regurgitation, if you take a look here, is almost greater than 2% or so in the general population, moderate to severe. It is certainly age dependent, just like most valvular heart disease. Little predilection for male sex and more prevalent in hypertension that obviously will cause further aortic regurgitation. So I'd like to take a look at it not only from a pathophysiological point of view, but also how do we evaluate aortic regurgitation in the current era. Interestingly, I chaired the scientific sessions of the ACC back in 2000, around the turn of the millennium here. And at that time, there was, very little, it is flat. And then you could see an increase in research regarding aortic valve regurgitation. Yes, it is less than aortic stenosis because this is where TAVR procedures came on board. And the interest is not only in procedures, but also understanding more the pathophysiology with the introduction of cardiac MRI. And so these two non-invasive methodologies, echocardiography and cardiac MRI, are complementing, and we will talk about that. So today we'll review the pathophysiology, how we fine-tune the quantitation of severity, look at the insights from advanced imaging, and also address prognosis, because most of us are clinicians and we have to help the clinician to try to understand the disease and when to intervene and the various approaches. So from a pathophysiological point of view, it is rather simple, I would say. You have a volume overload into the ventricle with more and more aortic regurgitation, so the ventricle starts enlarging. And it is a volume as well as pressure overload. We will emphasize that down the line. And ultimately, the ventricle, gets quite enlarged and may start showing some signs of decompensation. Patient symptomatology usually is dyspnea, heart failure equivalent, if you will, be it with exertion or at rest. So these are the things that we will be watching for in our patients. The presentation of acute aortic regurgitation are one acute, and the other one is obviously the chronic situation that we see most of the time. The etiologies in acute are narrow, endocarditis, type A dissection, and traumatic. and it can cause a challenge to the imager as well as the clinician because um, they presently acutely ill. The AR murmur may not be that impressive because of near equalizations of pressures. And interestingly enough, I mean, all these are basically transesophageal echocardiograms. On the transthoracic echocardiogram, the duration of AR, the color Doppler may not be impressive at all. So you have to think deductively in a way that low systemic output. But interestingly enough, actually, the uh, continuous wave Doppler and of the aortic regurgitation jet has a very short pressure half-time, near equalization of pressures. And although in the chronic situation is the least accurate of all the parameters that we use, in acute AR, it may be the first one that would alert you to something really bad going on in the aortic valve. Now, in chronic aortic regurg, uh, you as the imager, in addition to the clinician, have to think beyond just degenerative valve disease because it can be associated with congenital abnormalities, just like you see here early on in bicuspid aortic valve. You have to think about aortic root issues, some of the aortitis, the congenital abnormalities, etc. So, from a pathophysiological point of view, I think it's important to widen um, your differential diagnosis in addition to obviously enlargement of the aortic root per se. Now, this is to the clinician. You have all these signs that have various names on them. We're not going to go through them, but interestingly enough, all of them, okay, except probably the Austin Flint murmur, all of them are because of the wide pulse pressure, the high volume, high systolic pressure, and low diastolic pressure, and the high pulse pressure that you can see them in different parts of the body. So how do we assess aortic regurgitation? These are the guidelines. Then time is flying because next year will be 10 years of the update. The first one was back in 2003. I was honored to chair both of them. And in truth, these criteria that we'll talk about are still valid. Now, we may think a little differently about severity of the regurgitation, but the parameters that you will see have been there with us for quite some time, and the way we evaluate them may be a little differently, but the parameters are still the same. And what does the guideline emphasize? One is it's important for the imager, in addition to the clinician, to identify the etiology and the mechanism, understand how do you do an integrative approach of assessment by transthoracic echocardiography, understand when is transesophageal or MRI indicated in these situations. And, for your information, there is on the web from the American Society of Echo several case presentations, different things that I think could sharpen your diagnostic approach to this. I already alluded to regarding the mechanism of regurgitation. I think we as imagers have to look at the two major things. One is the cusps, and two is the aortic root. And is the aortic root per se enlarged and part of the mechanism? And does it affect also the ascending aorta, particularly in congenital abnormalities? So you may have to widen your imaging beyond echocardiography to take a look at the associated abnormalities in the ascending aorta. So it's very important to understand the mechanism. And what are the criteria that we use for severity? It's not a single one. Number one, we talked about the mechanism. Two, LV enlargement. In chronic aortic regurgitation, there is really no situation where you have significant aortic regurgitation without dilatation of the ventricle. So I think this is very important to keep in mind, particularly when you have eccentric jets that are difficult to evaluate. So LV enlargement, as you will see, the data supports that very, very importantly in chronic as opposed to acute aortic regurgitation. Doppler, you take a look at the three components of the jet: diastolic retrograde flow in the aorta. Hopefully, your trainees and yourself know how to do regurgitant volume and regurgitant fraction with echocardiography. And I put pressure half-time at the last one because from a diagnostic accuracy in chronic aortic regurgitation, it's not as good as the other criteria we just talked about. So this is color Doppler. These are the three components of the jet. Flow conversions, the vena contracta, which is basically tells us a bit about the area of non-coaptation, and then how does the jet behave into the LV outflow tract. Here it is, central, so it's less problematic. However, you can have very eccentric jets, and these eccentric jets, because the cusps are not symmetrically coapting in diastole. So this is not only seen in bicuspid aortic valves, where this is usually very prevalent, but also in aortic tricuspid valves, where you have some prolapse of one of the cusps compared to the other. So if you could see this, flow conversions can tell you something about it, but you cannot use the traditional, means of color Doppler, and therefore you have to use other parameters to try to help you. So in eccentric aortic regurgitation, the reliable indicators of severity, yes, you could use at times vena contracta, and in our experience, maybe about 70% of the time. Others, just like this one, is very hard to assess what's the vena contracta, but you have an idea that this is not mild aortic regurgitation, and you need to evaluate it with something else. And the something else is flow reversal in the aorta. Calculate regurgitant volume and regurgitant fraction. Obviously, look at the LV size. And less reliable in those situations. Certainly, you cannot use at all, the jet width in the LV outflow tract. And in those situations, or just like in this case here, if you want to record a continuous wave Doppler of the jet, best actually to go from the parasternal window because you have to follow the direction of the jet. From a quantitation point of view, this is regurgitant volume and regurgitant fraction calculation. We use either the total ventricular output or by Doppler, the output into the LV outflow tract compared to either right ventricular stroke volume or mitral stroke volume. And you could use either in those situations, can calculate the difference, which is your regurgitant volume, and divide it by the total volume, which will give you the regurgitant fraction. So in those guidelines that I know most of you are familiar with after 9 years of reading them one way or another, is we try to put in algorithm that took us almost about a year to put together and try to help you as to one specific criteria for severity, either severe or mild, where you really don't need to necessarily sit down and quantitate. And these are the flayed leaflet, the color Doppler, all the other things that we just talked about. And in situations where it is difficult to evaluate either the mechanism or the severity, we would recommend for you to go to more advanced imaging, either transesophageal, particularly understanding the mechanism, let's say in endocarditis, where it is more valuable than cardiac MRI. But cardiac MRI is very important for quantitation if you cannot quantitate for whatever reason, and you're still wondering about the severity of aortic regurgitation. So cardiac MRI is really an amazing technology. Beautiful pictures, and not beyond beautiful pictures, give you an extensive evaluation of the valve, the remodeling of the ventricle, the aorta itself, and the mechanism of aortic regurgitation. And this is an example of how you quantitate the severity of aortic regurgitation by phase contrast, in addition to ventricular volume. So the forward stroke volume here is 138, a reversal that you could see here, and therefore you can calculate the regurgitant volume and regurgitant fraction in these situations. We had the opportunity, and we were able to do this over a few years, is to get almost simultaneous echo and MRI within the same day, within a few hours of each other. And this is what you would expect in case you refer somebody from echocardiography to cardiac MRI, because most of the time these are referrals, as cardiac MRI is not usually the first line of imaging to assess aortic regurgitation. So exact agreement by grade 1 to 4 is above 50%, usually between 50 and 60%. And in this population of 64, concordance within 1 grade, which is acceptable, meaning if you say mild, between mild and moderate, or moderate and moderate to severe, something like this. So if you accept 1 grade difference, it's about 95%, but you still have between 5 and 10% at most, some 2 grade differences which have impact on management. And therefore, in those situations, you have to understand why the difference, and hopefully the clinician and the imager would go back and try to understand why with these differences. Usually, the majority of these difficult situations are very eccentric aortic regurgitation that echocardiography may not be as good as MRI. So I think in those situations, really the gold standard usually is a cardiac MRI. And so with that in mind, you have these criteria that we proposed a few years ago as to the specific criteria, and we asked a question since now we have an independent standard that is very reliable. What is the comparative accuracy of these criteria that we, set out? Because we know they're important, but we're not sure that they're about the same accuracy or same impact. And we recommended, yes, for you not to quantitate if you have about 4 of them. Are 4 of 6 criteria needed to confirm the severity without quantitation? So this is an important slide for you regarding, these various parameters. The parameters of color Doppler as well as end diastolic volume are not only specific but also sensitive, meaning you could take a look at their sensitivity and specificity and the area under the curve. So if I have a decent color Doppler that I can measure either the vena contracta or the jet width ratio and a large ventricle, I can understand and predict accurately what a grade 3 and 4 aortic regurgitation. Reversal of flow in the abdominal aorta, we knew that all along, that it was very specific, 100%, but not sensitive. So if I don't see it, it doesn't mean that there is no severe aortic regurgitation. Pressure half time is the least accurate. In addition to end diastolic velocity of reversal in the flow aorta, it is specific, but not sensitive, as you could see here. So these other criteria are specific as suggested by our guidelines, but no, they're not sensitive enough, meaning don't be fooled if you don't see them. Aortic regurgitation severity can still be important. So a combination of color Doppler and LV remodeling is sufficient for diagnostic significance of aortic regurgitation. So you don't need all these 4. And we'll have, soon another publication in JACC imaging as to it's important to look at it from a hierarchical point of view. Start with color Doppler and a ventricle, and then you can add the other parameters from a diagnostic purposes. So what we suggested in this publication, 2 years ago, that these are these are your, if you want to call it, major criteria, which are color Doppler and end diastolic volume. The others are supportive, but they're not as sensitive, so be careful not to underestimate the severity of aortic regurgitation. We have not talked about CT. I think CT, you will see publications on it and measuring the anatomic area of non-coaptation. Really, that's an extra, and if you do a CT, but you're not going to do a CT for assessment of aortic regurgitation severity, unless you want to take a look at the aorta itself, which is, I think it's better to have both function as well as anatomy with cardiac MRI. Certainly CT is very important from a coronary anatomy point of view. So this is diagnostics. 2 is, there is a changing landscape in aortic regurgitation regarding prognosis and what are the parameters. So if you take a look at the ACC AHA guidelines, which I know are being revised, if you take a look at severity here, we talked about how do you assess severe AR. But if you take a look at what triggers in an asymptomatic individual an intervention is an ejection fraction greater than 55% and a remodeled ventricle and systolic dimension greater than 25 millimeters per meter squared. So the question is, are these quantitative parameters accurate in reflecting severity? Two, are there any new LV remodeling parameters to consider for prognosis? And third is, in the era of TAVI and others with valve sparing procedures pioneered in a way in Toronto by Dr. Tyrone David, where are we nowadays in this? First is, I want to alert you that the guidelines in a way may be misleading, and I want to make sure that you understand the differences in pathophysiology. In the guidelines of ASE, ACC, and European Society of Cardiology, the severity, quantitative severity of mitral regurgitation and aortic regurgitation is identical. And part of the reason is we did not have a true validation or independent approaches to quantitate these. So they're the same. And the question, should they be similar, meaning grade 1, 2, 3, and 4 from a quantitation of regurgitant volume and regurgitant fraction are identical? And we know that these two diseases are indeed different. From back in the early days of Blaise Carabello, we're talking about here more than 40 years ago. Take a look at the differences in myocardial performance between mitral, and this is chronic, mitral and aortic regurgitation. And you could see in the hashtags that in aortic regurgitation, the stress on the ventricle is much higher. And we know this is not only a volume load, but a volume and pressure load because the ventricle is ejecting into the aorta in addition to the volume load. This is early. Actually, to tell you the truth, this is when I was a junior faculty, this is the one that piqued my interest. This is validation of regurgitant volume and regurgitant fraction, the first one actually, with echocardiography. And if you take a look here, the triangles are significant aortic regurgitation as opposed to the circles, which are mitral regurgitation. So regurgitant fraction, you rarely see in aortic regurgitation a regurgitant fraction greater than 60%. Most of the time, you're going to see the significant ones close to 50, maybe in the 40s or something, as opposed to MR, where you have regurgitant fraction easily in the severe range between 70 and 80, etc. And interestingly enough, if you operate on these aortas, your ventricular function improves, right? As opposed to mitral regurgitation, where you may have a diminution early on. And these are early data from Dr. Uretsky, taking a look at regurgitant volume versus LV end diastolic volume and different remodeling between mitral regurgitation and aortic regurgitation, where the ventricle has remodeled much more in aortic regurgitation. We took advantage of data in our center, and we have a very really nice registry put together by Dr. Deepanchal, who's the head of MRI in our institution. And I wanted to see what are the differences in cardiac remodeling in left-sided valvular regurgitation between aortic and mitral regurgitation, because it will tell us something about severity, it will tell us something from a clinical point of view. So we looked at data and a large cohort of data. We did not want to have depressed ventricles. We did not want to have ventricles with ischemic scar, or LGE, greater than 5%. And so we're talking about close to pure aortic regurgitation and pure mitral regurgitation, a cohort of 1,500 patients plus. And notice something that makes also sense physiologically and will impact in a way how we think about aortic regurg versus mitral. Above a regurgitant fraction of about 30% or so, there is significant differences between aortic regurg in green and mitral regurgitation in remodeling of the ventricle. So for the same volume, regurgitant volume or regurgitant fraction, The ventricle gets larger and larger with aortic regurg, as you would expect, be it in diastole and systole, LV mass index, ejection fraction, basically telling you what we knew from many, many years, that AR and MR are two different diseases. And in a way, in the guidelines, we really cannot have them in the same bucket, if you will, or the same criteria for severity. So yes, we evaluate them with all mitral regurgitation, with cardiac MRI, and we looked at the prognosis of these individuals, right? So 38% underwent AVR who did not meet the criteria. And some of them had symptoms, some of them had significant remodeling. And take a look here. These are the traditional class 1 indications for aortic valve replacement or repair. 50% regurgitant fraction, 60 ml of regurgitant volume. Notice how specific these are, and they're not as sensitive, meaning individuals will get either symptoms or significant remodeling, before we get to these levels. And therefore, the sweet spot, or the best in the AUC curves, were about almost 35 to 40% regurgitant fraction and about 40 ml or 50 ml of regurgitant volume. So we have to, in a way, simplistically, if you have a grade 3 aortic regurgitation, don't think of it of a mild or moderate disease. It's really significant disease. And the larger the regurgitant volume and regurgitant fraction is, the most likely, the faster these individuals will get to a point of intervention. So what we proposed is basically a 10% less of regurgitant fraction and 10 ml less for regurgitant volume. And you'll see the curves here of, if you have a regurgitant fraction less than 20%, even up to 8 years or so, this is really mild. But regurgitant fraction between 30 and 40%, a certain percentage will need to have an intervention on the valve, and above 40%, most of them will. So in summary, regarding these situations here, we know echo Doppler is the first line. Quantitative cutoff for severity are likely lower. They have not changed the guidelines yet, but I'm sharing with you data from our institution and other institutions that for AR, probably the cutoffs are less. Advanced imaging with TE or CMR, if you have a poor transthoracic quality or low confidence in Doppler parameters or discordant findings, you need advanced imaging. And these are particularly in eccentric aortic regurgitation, where we have in echocardiography more issues. If you need to understand the mechanism of significant aortic regurgitation, how is the root, how is the ascending aorta, etc. And these are my recommendations for you as the choice of advanced imaging modality. When do I choose a TEE and when do I choose a cardiac MRI? I would choose a TEE if I need more refinement of the anatomy that cardiac MRI may not tell me about, meaning particularly vegetations or a perforation of the valve. If I have an eccentric jet, a transesophageal is not going to help me. And the reason for it, I will still have an eccentric jet. I may see the color better. But if I need quantitation, cardiac MRI would be the best modality, second modality after your transthoracic. And certainly if I need more evaluation of the ascending aorta, and if remodeling and fibrosis is important. So the second one is, are there any new parameters for LV remodeling for us to consider from prognosis? This is rather simplistic. If I have an EF of greater than 55% or a ventricle that has remodeled in an asymptomatic individual, probably it's a 2A recommendation, or ultimately will probably be a class 1 indication. Remember, as opposed to mitral regurgitation, if I have any depressed ventricle, the prognosis is better if we do something about the valve. And and fix the aortic regurgitation. So keep those in mind. From a prognostic point of view that supports the guidelines is if you take a look at ejection fraction, either linearly, meaning using fractional shortening, or volumetric ejection fraction, the cutoff is about 55%. If you recall, some of you were in the previous guidelines, it was 50%. And part of the reason to be 55% is, again, these prognostic data. You could use GLS, which is global longitudinal strain. In truth, I rarely see a GLS less than 15% unless the ventricle has already, been depressed in a way. But if you have it, I think it's another quantitative parameter that you could use. This is end systolic LV diameter index. Remember, in the guidelines is 25 millimeter per meter squared. And these are from two different publications. There is an inflection point after about 2 centimeter, if you will, per meter squared. So between 2 and 2.5, you have to kind of look at the overall patient, the progression. Are they younger? Do you want to postpone things further? But, you'll keep a closer eye on these individuals. And this is data from a multi-center CMR study, which consolidates what I just shared with you. This is headed by Dr. Balhafshi from our institution, and a collaboration between Duke, Piedmont, and Atrium and Houston Methodist, published about 3 years ago, and basically shows you the same data, meaning that your best cutoffs from a prognostic point of view are lower than the guidelines tell us. LV and systolic dimension of about 4 centimeter or so, a regurgitant fraction of about 43%. So an systolic volume 43 or so per millimeter square. And this is the central figure summarizing these situations with the cutoffs. So remember, from a practical point of view, if you're thinking about a grade 3 almost aortic regurgitation, keep a close eye on these individuals, similar to the close eye that you keep on a grade 4 regurgitation, because the remodeling may mature earlier and the patients may get more symptomatic. Other parameters with cardiac MRI now is some newer parameters. Basically, if you have late gadolinium enhancement, you have worse prognosis. And this could be regional or global. Remember, most of the studies that we've done, other people have done, are almost the pure aortic regurgitation. The question, if you combine it with other diseases, a cardiomyopathy or ischemic heart disease, the prognosis will be worse, certainly. And I think these need to be evaluated further down the line. Another parameter by cardiac MRI besides LGE is the ECV, which is the extracellular volume index. And basically, if you have, more diffuse fibrosis, if you will, and an expansion of the extracellular volume index, your prognosis is not as good. So one thing I wanted to share with you, which is, this is in the current era of machine learning and AI. This is a study that we've done here, which is interesting because it is intuitive in a way, looking at letting AI tell you about various prognostic buckets, if you will. And basically the phenoclusters that happen with AR, and this is the best prognosis right here, which is the younger patients, predominantly male, although they have LV dilatation, but they have also bicuspid aortic valve, they're among the better ones. Then older patients, predominantly male with tricuspid aortic valve, older patients, predominantly female with LV dilatation, that is not as prominent as the others, so they get more symptomatic early on. And the worst kind of prognosis or phenotype, if you will, is the older patient, predominantly male, with a lot of scarring, comorbidities, and LV dysfunction. It makes clinical sense. It is rather intuitive, but it's nice to see it that an independent technology from aortic, from artificial intelligence can give you different phenotypes in this situation. And last, what I want to share with you is what are we doing nowadays in the interventional arena of repair, valve sparing. I think Toronto is one of the major hubs for valve repair and aortic root repair. From a general point of view, obviously, the more symmetrical the valve with bicuspid aortic valve, the easier the repair. So structurally, it should be good, not calcified, etc. But the more symmetric it is, the better it is. The surgeon would look at the structure of the aortic root as well as the valve with various measurements. So I think good imaging, I think, is very important in those situations. From a historical perspective, this is the first publication from the Bental procedure itself, where you have aortic root, repair and replacement in addition to reimplantation of the coronaries. Publication from Dr. David telling us, and I think, experience also shares with it, is a valve sparing procedure is better than any prosthetic valve and composite graft that you, be it mechanical or biologic. This is from a randomized trial in Europe, looking at aortic valve repair versus mechanical valve replacement, also a better prognosis when you have repair and sparing. In the era of transcatheter valve interventions, this is actually the first valve that is approved for such just recently. And this is from the Jena valve, structure obviously tailored for this because at times the aortic root is larger than an aortic stenosis. And you could see from the early trial that the symptoms after, taking care of the aortic regurgitation certainly improved. And this is such a case for you here with the Jena valve itself. Now, as you probably know, that the European Society of Cardiology came up with a revision of their guidelines back in October and August last year. And actually, some of these that we just talked about, not all the parameters that we talked about are incorporated. So particularly the most important thing for all of us is the asymptomatic patients. When do you intervene on an asymptomatic patient with significant aortic regurgitation? So LVEF less than 55%. The end systolic dimension index a little less. Remember the 25 versus 20, so somewhere there in between. So keep those in mind. And this is the new incorporation of end systolic volume index of greater than 45 ml per meter squared. Interestingly enough, this number is similar between echocardiography and MRI. And interestingly, although we underestimate usually, but in end systole, probably the underestimation is less from volume's point of view. So in summary, regarding the changing landscape, I think it's important for all of us when we assess aortic valve regurgitation to take a look at both aortic valve and structure and the mechanism of AR. And nowadays, you have all the imaging technologies to tell you. So cardiac catheterization is not the place for us to understand the mechanism of the disease. Severity of the regurgitation, most likely the regurgitant volume and regurgitant fraction are a little lower from a severity, and they're different than mitral regurgitation. This is my proposal here. Irrespective, think of the usual grade 3 as an important one, not only a grade 4, because in the guidelines tells you it's grade 4, and therefore take a look at if the patient are symptomatic, yes or no. Evolving prognostic markers in asymptomatic patients, we talked about, end systolic dimension, end systolic volume, presence of LGE on MRI, and extracellular volume index of about 24% or so, and by echo a GLS less than 15%. Consideration for patient population, it's always important for you when we try to intervene on these patients' age, is the valve bicuspid. Women, which could be more symptomatic a little early on, what's the aortic root, what are the comorbidities like, and the various interventions appropriate, particularly, I mean, I know I'm talking to areas where the valve repair has been developed very nicely, is keep in mind, and in areas where you don't have the surgeon to be able to do it, I would refer them to where the surgeon can do a valve repair if it is appropriate, and as well as valve sparing procedure. And TAVI data is really very promising. The ALIGN trial showed efficacy, safety, as well as prognostic information. And it is actually the first valve that has been approved for such in the United States. So that's what I wanted to share with you regarding the various changes nowadays in approach to aortic regurgitation. This is our team. I know you're familiar with most of them. This is Dr. Deepan Shah and Mike Quinones and Steve Little. I know you know many of them. And I would love to invite you to come to Houston. This is our Texas Medical Center. And two other areas besides this grand rounds with you is that you could stay in touch. One is through our YouTube channel. I was discussing it early on before we started. We have live grand rounds on Thursdays. Here you go, just Thursday at just after your after your rounds here. Actually, it'll start in a few minutes. For echocardiographers or cardiac or imagers, every Tuesday noon, it's live, but all of them are archived for you to access. And for those of you either want to join us virtually or you want to come down to Houston in October, this is our 15th year, believe it or not, time flies, of multimodality imaging, and it's almost for free. So we would love for you to participate. And thank you again for this wonderful invitation and for the opportunity to share some of these data with you.